This meeting is being recorded.
Hello, my name is Joellen Lee, and I'm a pediatric nurse practitioner in the Division of Neurology at Nationwide Children's Hospital in Columbus, Ohio. I'm going to talk to you today about many cases of pediatric stroke, and this is for the APP to APP lectures. I've been a pediatric nurse practitioner for too many years to count now, but I've been in the section of neurology for the last 17 years and in the stroke clinic at Nationwide Children's since its inception. My goal today with talking about this is to really do an overview of the different types of stroke that we see in children, and then to also talk about some of the advances that we've seen, but really not talking a lot about management. I have nothing to disclose. I am involved in recruiting of subjects for different research studies, but I don't have any direct financial relationships. So by the end of this program, my goal is for the participants to be able to differentiate between the different types of pediatric stroke and to discuss treatment options, including the advances that we've had in pediatric stroke care. So when we talk about pediatric stroke, we're going to talk about 4 different things today. Arterial ischemic stroke, which most people are familiar with, cerebral sinus venous thrombosis, and then those perinatal events, perinatal arterial ischemic stroke, and then presumed perinatal stroke. So there's many types of pediatric stroke. Let's first talk about those that are perinatal. Those occurring after 20 weeks of gestation up to 28 days of age. And those can be the perinatal arterial ischemic stroke, which we call PAIS. We also include perinatal venous infarctions, and then presumed perinatal ischemic strokes, which are those that have a delay in their diagnosis. Childhood arterial ischemic stroke occurs in those children after 28 days of age through adolescence. And this occurs when there's blood flow in an artery to the part of the brain that is blocked by an embolism, narrowed or damaged artery. We also have hemorrhagic stroke that can occur in any of these age groups, and it may be secondary to venous congestion. And then cerebral sinus venous thrombosis can occur in either age group and occurs when a blood clot develops in a venous sinus or a large deep vein of the brain. In some of the neonates, it can even develop into those smaller cortical veins and have involvement. But it's important to remember that strokes can happen at any age. Strokes in children are sometimes more difficult to diagnose because sometimes they'll mimic other kind of symptoms. So that's why sometimes there's a delay in the diagnosis for stroke in pediatric patients. Because of that lack of awareness, when I first started with the stroke clinic all those years ago, people would ask me, so what do you do at Children's? And I would say, I'm part of the stroke clinic. And they'd say, kids have strokes? So, lots of education has been ongoing with that. But one of the problems is that our median time from symptom onset to the parent seeking care can be anywhere from 1.7 to 21 hours. With an average of 6. And if you think of in the adult world, where you're looking at time for the hospital to needle time of 4.5 hours when you're looking at TPA, we're way out of that range. There's also a delay in getting radiologic confirmation because MRI scan is the best for children, where CT scan is used for adults. CT scan for children is not always reliable. So sometimes there's a delay in just getting that MRI scan. Neurologic deficits can be overlooked in children, and that may be because some people aren't used to examining children or just not familiar with what some of the deficits might look like. Or they can have TIA symptoms that can be more attributed to behavior or just cooperation. Some of the symptoms can be transient, and some of them can be very subtle, so that can delay that appropriate diagnosis. There's also things that can be mimics of stroke. Common things that we see in pediatric patients, such as migraine with aura, or even less common hemiplegic migraine, look exactly like somebody having a stroke. There's also a condition known as alternating hemiplegia of childhood, where they'll have episodes of weakness on one side, and the next side, they might have that weakness on the other side. Seizures that are followed by Todd's paralysis, Bell's palsy, CNS infections, CNS tumors, some metabolic diseases, They could be intoxicated, where you have altered consciousness, traumatic brain injury, and then conversion disorders sometimes will mimic stroke symptoms. So Dr. Piquet is a pediatric neurologist that practices in Australia, and he has had a real interest in stroke mimics and did a few articles on this. But he looked at, for those things that we see, the symptoms that we see in a pediatric emergency room, what are associated with stroke and what are not. So the symptoms that can be associated with stroke were that the child was well the week prior to them coming in, and that's seen more often with hemorrhagic stroke. Their inability to walk, more likely associated with stroke, or if they have focal face or arm weakness, more associated with arterial ischemic stroke. Having visual changes, it was more associated with migraine, but I always say a caution with that, because if there's an occipital stroke, then you can also have some of those visual changes. Symptoms that were non-discriminatory or really didn't say, were a stroke mimic or really didn't point to one direction were things like seizure, altered mental status, and sudden onset of symptoms. So let's talk about arterial ischemic stroke. This is one of the patients I've taken care of, a 16-year-old female who had a sudden onset of right-sided facial paralysis and paresthesias. She had double vision, dysarthria, nausea and vomiting, vertigo, and swallowing difficulties. And these were all new onset for her. She had never had any other symptoms that made you think that she ever had another stroke. In the right lower corner, you can see a DWI scan, and it shows a new TWI scans will show new as being bright in her cerebellum, most likely in the pica kick territory, or we thought maybe she might have a vertebral artery occlusion or possibly dissection, which she ended up not having. But also on her scan, in her T2 coronal, you saw an old left frontal infarction. And again, she never had any other symptoms with that. She was positive when we did her thrombophilia workup for a factor V Leiden mutation and was placed on anticoagulant, then was placed eventually on aspirin, and then she eventually just stopped taking it. And the last I saw her, she was in her 20s and she was doing great. Did not end up with any kind of deficits at all. Occasionally would still maybe have some vertigo here or there, but not anything that was keeping her from living a normal life. So what do we see for incidence and epidemiology for stroke? It's one of the top 10 causes of childhood mortality in the United States. The incidence, though, is pretty low, 1.3 to 5.4 per 100,000 per year in the United States. There is a mortality rate of about 4 to 5%, but in 50% of the cases, that's more related to their underlying condition. In children, ischemic and hemorrhagic stroke occur equally, where in adults, you see ischemic stroke much more often than hemorrhagic. It's seen more prominently in African-American children, more than white, but that's not explained by those that might have sickle cell disease. Boys more often than girls, and they think that might be related to trauma. And the age for stroke, they're most at risk under a year of age. And then we see not a lot of stroke. And then again, during adolescence, we see some peaks again. And then of course, in the elderly population. So what are some causes of arterial ischemic stroke? Definitely can be cardiac. And this can be both those that have congenital heart disease or have acquired heart disease. Different arteriopathies, and we're really looking into cerebral arteriopathies that occur very transiently. Other acute systemic conditions like infections, anything that's hematological or oncological, definitely those children who have leukemias, other tumors that are on chemotherapy, it can increase their stroke risk. Chronic head and neck disorders, those hypercoagulable states, both acquired and inheritable. And then mitochondrial disorders. There's one called MELAS, and they have repetitive strokes. Or any kind of trauma can be some of the causes behind arterial ischemic stroke. One of the delays in diagnosis for these children, which we sort of already talked about, is They can have waxing and waning onset of their symptoms, and that occurs in about 13% of those that have had stroke. They can have a progressive onset, so slowly developing those symptoms, but it can occur over even hours to days. And then 51% will have an abrupt onset. The majority of children will have some kind of weakness, hemiparesis, or hemifacial weakness in 67 to 90%. Seizures occur more often in younger age children, 15 to 25%, but could be focal, generalized, or a combination. They could start focal and go generalized, so it could be a definite combination. Changes in their walking or they're ataxic, 8 to 10%. Headache is seen more common in children than it is in adults, between 20 to 50% in children versus about 25% in adults. They can have an altered mental status, visual loss or changes. Again, you have to think about an occipital stroke, and they can have some papilledema. Changes in speech, they could be having a stroke in the dominant frontal area or the Broca region, or in a posterior temporal area, Wernicke's, and that occurs in 20 to 50%. Vomiting, they can have other focal signs or non-localizing features. And again, with anything that has to do with the brain, location is key. Red flags can be vomiting without fever, double vision, and ataxia, which makes you think of a cerebellar lesion. And those, because of inflammation and swelling, and it's in a tight place to begin with, can go from a child being alert to a child being comatose. So what are the outcomes, or what kind of things that we know from pediatric stroke, arterial ischemic stroke, that can be predictors for outcomes for children? If there's a larger infarct volume in younger age, that's associated with a poorer outcome. Definitely poorer psychosocial and cognitive function. Other functional outcome predictors can be if it's an infarct that's in an area that's a connector. So an area like the basal ganglia or the posterior limb, those are connector areas. And so then they have a tendency to have worse outcomes. Better outcomes if they use rehab services, meaning if they had therapies for their treatment. Seizures can predict a poorer outcome, especially in that acute time period. Arteriopathy can lead to a more abnormal functional outcome. We do have a pediatric stroke outcome measure, and it's measures on if there's hemiparesis, cognitive functioning. And so if the score is 2, there's less functional recovery. And just like with adults, you see most of your recovery within that first year. And that really predicts what your long-term outcome can be. There are 35% of those children who have had arterial ischemic stroke that end up with some kind of psychological or psychiatric disorder, anxiety or depression. But unlike adults who may have that initially, this is something that may develop over the course of time. There are about 30% that have normal outcomes, and 70% that have the deficits. 36 are mild, 23 moderate, and 10 are severe. There was a study done that looked at all different kinds of stroke factors. And one of them looked at Canadian data where they looked at the Wechsler scales of human intelligence. And everything was lower than those that you would normally see in a population of that age. If they had injury to cortical and subcortical areas, they performed more poorly versus those that had injury to either cortical or subcortical. And definitely we see problems with poor attention, impulsivity, and executive functions. They also looked at quality of life and noted that it was significantly lower across all children, all domains. And then the cognitive and behavioral deficits, low verbal IQ, that also affected their quality of life, primarily on older children and females. However, their overall neurologic outcome and family socioeconomic status did not affect their quality of life. And those with motor and speech problems, about 55% had hemiparesis and 21% had speech difficulties, and those were considered in the mild. And then they looked at long-term outcomes of adults who had stroke as children. And you have to think about, it may have been 10, 15, 18 years since they'd had their stroke. 80% said they had complete recovery or had a mild deficit. And greater than 25% reported mental illness. So we know that in the pediatric population where they did that, it was 35%, and primarily depression and anxiety. Also, if they had rehab in that first year, maximal outcomes. And these would be people that have had strokes a while back, but we had improvement in those scores. Presence of epilepsy also led to poorer scores. They had problems with memory, executive function, fatigue, and those that had greater initial severity and longer duration of follow-up had more risk for unemployment. But overall, we see kids with pretty good outcomes in general. Hemorrhagic stroke, definitely associated with arterial ischemic stroke, but I just wanted to mention it because the risk factors are about the same. Your prognosis is going to be about the same. And in this care, we have one of our neuroradiologists that does like to do the arrow signs, is what we all call them. But you can see some central areas of hemorrhage here. This is in an SWI scan where bleeding will look black. You have bleeding into the ventricles and also some frontal lobe bleeding. This can occur after a significant ischemic stroke as a hemorrhagic conversion, or can occur after a cerebral sinus venous thrombosis when you have those deep medullary veins that can sometimes have hemorrhage. There's a 4% risk of intracranial hemorrhage secondary to anticoagulation treatment if that's utilized. But most often a hemorrhagic stroke is caused in pediatric populations by some kind of structural abnormality. 75% are caused by arterial venous malformations. They can be aneurysms, they can be cavernous malformations, but 10% can also be idiopathic. So again, lots of different causes for hemorrhagic stroke, very similar to your arterial ischemic stroke, except for that abnormality in those blood vessels. And premature birth, we see that more often with them. And then let's talk about the babies, which is the one area that, is very unique to pediatrics. We have those perinatal arterial ischemic strokes. The incidence is around 1 per 4,000 live births, but can range from 1 to 2,300 to 1 to 5,000. There's a slight male predominance. It's usually unilateral and typically affects the left middle cerebral artery. And it's thought to be due to those hemodynamic differences from a patent ductus arteriosus, and then that more direct route that it has with the left common carotid artery. With perinatal arterial ischemic stroke, it is the common cause of cerebral palsy and the second most common underlying etiology of neonatal seizures. It's easy to miss on a lot of newborns because they don't show you a lot of focal kind of symptoms. And babies will do all sorts of different movements, but the key is looking at repetitive movements, especially if you're looking for seizure for them. Children who have a history of perinatal stroke have a higher neurologic morbidity than those occurring later in infancy or childhood. Even though we talk a lot about the plasticity of the infant brain, there still can be some definite deficits with that. And children with a history of a perinatal stroke are felt to sort of grow into their deficits. So in infancy, it's very hard to provide accurate assessment of their future ability. I always tell parents, I said, I wish I had a crystal ball that I could say, when, Johnny is 6 years old, this is what he's going to be able to do. This is what he's going to struggle with. But there's many children that I can say, okay, they're probably going to have problems. If it's an MCA territory, we're probably going to have problems with motor function, and we might have some problems with executive function. If it's basal ganglia, we might be having some seizures. Anything in the temporal lobe, we might be having some seizures. But I've had so many kids that have proved me wrong. But we can try to give them some ideas of maybe possible deficits that they might have. When looking at risk factors for any of the perinatal kind of strokes, we have to look at not only maternal factors, fetal factors, but we also have to look at the placenta too. And you can see thrombophilias are one of those things that occur most often, but also looking at what happened during the course of the pregnancy. Anything with hypertension, such as preeclampsia, can increase that risk. And then looking at if there was any kind of insult to the placenta or infection. For the baby, again, the thrombophilias, If they have a congenital heart disease, can put them more at risk, arteriopathies. And then during the birth process or immediately after birth, did they have any complications? Infection, hypoglycemia, low oxygen, or needed for resuscitation? Or were there APGARs? What were they? Were they low? So most often these infants will present with some kind of seizure. And I always explain it to the parents as that, it's the way the baby's body is telling you, hey, look at me. I've got something going on. I need some help, because they're not able to tell us that I feel funny or my arm's jerking. Seizures are typically focal or clonic seizures and usually occur within that first 12 hours of life up to 3 days of life. Many of the patients I'll get, they're saying, yeah, everything was great. And on that, 24 hours, we're just about ready to go home, she started having this lip smacking that was very rhythmic. And we just didn't seem like we were able to stop it. She wasn't hungry. So repetitive facial movements, lip smacking, eye blinking, eye movements, bicycling or pedaling movements of the legs, staring off. I always say staring off is lights are on, but nobody's home. Any pauses in breathing, and then just any of that rhythmic jerking or tightening of muscles groups. Again, repetitive with that. 30% of them will have an abnormal neurologic exam, but that leaves 70% that have a normal exam. If they have an encephalopathy, you're more likely going to see a change in that level of consciousness. They can have a change in their muscle tone, respiratory issues, or feeding difficulties. So different things where they're having more difficulties in those first few days. For their outcomes, we see motor deficits most often, 48 to 59%, and then also speech. As they get older, they may develop neuropsychological morbidities, so problems with language, cognition, attentional problems, hyperactivity, and that occurs in about 60% of those children. There were initially some studies that show cognitive scores being in the normal range, but the ones more recently are showing that they're below normal. And we do see epilepsy in about 38 to 46%. Those that have a presumed perinatal ischemic stroke, they usually have a normal newborn course with presentation within those first 18 months of life. And they'll have those focal signs of hemiplegia. And then neuroimaging will let you know that they've had some kind of vascular event, usually in that middle cerebral artery or periventricular territories. There's no history that suggests stroke. And so this is presumed to have occurred sometime in that perinatal time period. Even somebody who comes in as a newborn, many times it's difficult to exactly date when that stroke occurred, unless they had some kind of problem or process with that. But this is an axial T2 of this was at about 18 months of age with a you see that very nice wedge shape of left middle cerebral artery. And this is one of my friends that I've seen since she was 7 months of age, female, born at 40 weeks to a gravida 2, para 2. Perfect pregnancy, no problems at all, but then needed an emergent C-section because of placenta previa, fetal distress, meconium aspiration, and pneumonia. She, did fine, didn't even need to have a chest tube because of the pneumothorax. And then mom started noticing at about 4 to 5 months of age that she kept her hand fisted all the time. And that she wasn't using that right side as much as she was on the left. And so she was seen by her primary care, who then sent her to physical medicine and rehab. They ordered an MRI and found this very nice left middle cerebral artery infarction. And you can see here she's already has some encephalomalacia, more of a cystic kind of area with that. But pretty much taking all of that territory of the MCA. Because she had that, and we knew that she had this rough course here, we did a little bit further investigation with thrombophilia workup. And she is also heterozygous for factor V Leiden, also for MTHFR mutation, and hypofibrinogenemia, which I can never say. So she has a risk of not only clotting, but also bleeding. And so she's one now that she's an adolescent and having her periods, that we really monitor her to make sure she's not having excessive bleeding. And when she was diagnosed with this, our hematologist, I always tell my students when we look at diagnoses, I said, if you hear hoofbeats, think horses, zebras, or snakes with high heels. And so this kiddo is a snake with high heels because hypofibrinogenemia is something that's very rare. So with presumed perinatal stroke, injury this is the same as perinatal arterial ischemic stroke. So thinking that this is really just an acute perinatal event. The diagnosis is challenging. There's many times that high clinical suspicion and early recognition. Those parents that come to you and say, oh, at 6 months of age, oh, I think they're going to be right-handed because they're always using that right hand. They really don't like to use their left hand at all. To me, that puts off red flags, blaring sirens that we need to further evaluate this. So studies have shown that the median age of parental concern is usually around 5 months of age. And if you think of normal development, head control, then arm control, and so about 5 months of age, they're bringing everything together and utilizing their hands a lot more. Provider concern is usually noted around 7 months of age, and the median age of diagnosis is about 12 months of age. The risk factors are very similar to the perinatal arterial ischemic strokes. Definitely if there's maternal factors during that time. And inherited thrombophilias are very common. But cardiac abnormalities are rare, where in perinatal arterial ischemic stroke, that's definitely one of the risk factors for those. So again, the presentation is usually an early hand preference or fisting, and that's seen in 81 to 86%. Sometimes it's seizures, sometimes it's a gaze preference. But you do have to remember, we can't just automatically assume that if they're having a handed preference or they're having some unilateral weakness, that it's automatically they've had a stroke. That's the first thing on my differential. But they could have some kind of other cerebral injury, spinal cord problem, anterior horn cell problem, peripheral nerve, neuromuscular junction. There could be lots of other different things that are going on. But it's only a cerebral injury, rarely spinal cord, that will cause spasticity with that unilateral weakness. With outcomes, the majority of these kids will have some kind of hemiparesis, and it can be anywhere from severe to mild. 50% will have some cognitive or behavioral difficulties, and 38% have some kind of epilepsy. They do have a higher morbidity and rehab need than children with perinatal arterial ischemic stroke. And there's not been a really good definition for that. We don't know, maybe this injury occurred earlier, or because they don't get their rehab therapies earlier, that delays the process. And so then they have more severe deficits with that. So that's something that research is looking into. And I recently saw a child who is now almost 3 who saw orthopedics because he wasn't using his left leg as well. They gave him some splints to use, actually some AFOs, and because he wasn't showing like lots of improvement with it, they finally referred to stroke, did his MRI, and he had had a perinatal event. And this has been, and he's almost 3 and just now getting that diagnosis. So there is delays. And I just wanted to briefly mention periventricular venous infarctions. These occur earlier in gestation than what we see with arterial ischemic stroke, and usually occurs more commonly in premature infants. It's felt to be somewhere along the germinal matrix prior to 34 weeks. And it may be just because of compression of the underlying medullary veins. There's more potential for leg involvement than with arterial ischemic stroke. Sensory deficits are usually less because you're not dealing with the sensory tracts. You're really just dealing around the ventricles. Less commonly found risk factors, and seizures are less common because it's more of a white matter injury than gray matter. So in summary, they're not rare. The likely incidence is even more common than what past studies have suggested. Etiology can be very multifactorial. I always tell parents, so many different factors that occur. It's a wonder that any of us are born without multiple deficits, because it is a miracle that we go through that process. Risk factors can be maternal, fetal, or placental. Left middle cerebral artery is the most common area affected. So the answer to the question of what is the artery that's most commonly affected for any kind of stroke, usually the left middle cerebral artery. Seizures are that common presenting symptom. Think of rhythmic behavior. They are the leading cause for cerebral palsy, and they do have significant neurologic morbidity. And if you think about any kind of injury to the brain, and like in adults, and then they go on, but think about for a child, this is going to be a lifelong problem for them. And so in early intervention, getting them into therapies, really monitoring their development can really help to improve those future outcomes. And then cerebral sinus venous thrombosis occurs when a blood clot develops in a venous sinus or larger deep veins of the brain. The smaller cortical veins can also be involved, but the mechanism may not be exactly the same. Sometimes the blood clot goes away before it causes any kind of permanent brain damage. However, other times the clot can also cause a venous infarction because of the extra pressure that it's caused, and it cause damage into the parenchyma. So you can see on this example, you've got a beautiful superior sagittal sinus. You go into that right transverse down into the right jugular, and the left side, there's something just not there. So this was a 6-week-old who was acutely ill with vomiting, decreased level of consciousness. He'd been in and out of the emergency room in the few weeks before he was actually admitted. He was found to have a sodium of 200, increase in his BUN and creatinine. And so the initial picture that you saw was his left transverse sinus thrombosis, but he also had a left thalamic infarct, which is the T2, where you can see it here. Again, our nice little arrow sign. And then also on the DWI, which will show you acute injury, you can see it here. He also had a little bit of enhancement along the ventricles, but that was more likely just artifact for him. He also had deep medullary vein thromboses. His thrombophilia testing was negative, and there was a big concern about how mom was mixing his formula. And so all of his issues, we think, were because he got dehydrated, and then he had hypernatremia. But he is now a school ager, and he is doing well. Has a little bit of some behavioral issues, but actually overall doing well. And does have some seizures, but well controlled. So with cerebral sinus venous thrombosis, just remembering your anatomy of the superior sagittal sinus, straight sinus, inferior sagittal sinus, transverse, sigmoid, internal jugular vein. I like this picture because it gives me all of those. Does not occur as often as what we see for pediatric stroke, but is more common in neonates. And if you think of birth process and how you can get some hyperviscosity of the blood, that can put them more at risk for that. So the majority we usually see are neonates. 60% of neonatal cases are because of prematurity. Mortality is fairly low, 3 to 12%, but the neurologic sequelae can be 62%. And that's a question, because if they don't have parenchymal damage, why are we seeing them having some neurologic sequelae? And that's where future studies are looking at. So most often seen in younger ages. Risk factors, looking at both neonatal and child risk factors, can be lots of different things. So I'm just going to give a little summary. Neonatal, a lot of times it's a delay in diagnosis. You have to look at maternal conditions and then also the perinatal conditions. What happened during the birth process? Was there any asphyxia? Do they have an infection? Do they have things that can make the blood even more sluggish? So polycythemia, dehydration, and congenital heart disease. For a child, what kind of prothrombotic conditions or hematologic conditions do they have? Are they on chemotherapy? Do they have acute provoking illness? I've had a few kids that have had really horrific ear infections, chronic, one right after the other, or a mastoiditis that then have led to them having sinus venous thrombosis. Dehydration, more than one child I've had, that was sort of a cascade. They got dehydrated, and then they got an infection, and then they got more dehydrated, or they just weren't taking care of themselves, and they developed a cerebral sinus venous thrombosis. Those that have cardiac disease, systemic illness, those head and neck infections, or autoimmune disorders can make them more predisposed, like irritable bowel syndrome can be one of those. Lupus can be another one. This is also still my 6-week-old, who you can see this is probably one of the most beautiful pictures of where you can see the retained thrombus there right along that transverse sinus. So your signs and symptoms can develop gradually, not like when you see acute stroke where, majority of the time you'll see a quick onset of symptoms, but most often headache, nausea and vomiting. It can be altered consciousness, lethargy, focal deficits, nerve palsy, sixth nerve being one of those. So you're seeing a difference in how their movement of their eyes. Seizures are seen more in neonates. When you're looking at more the transverse sinuses or those that were right around the eye or around those cranial nerves, then you might see ringing or hearing other sounds in their ears. Sometimes they tell me they hear oceans in their ears. Symptoms will vary depending on the location of CSVT, and we'll talk about that with our next slide. But neonates can present with those non-focal deficits. Most often you're going to see headache with these patients. So this shows you that the higher up you are, superior sagittal sinus, inferior sagittal sinus, straight sinus, you're going to more likely have those motor deficits, seizures, mental status changes. So upper, you're going to see those. Lower, transverse, internal jugular, sigmoid, and cavernous sinuses, you may have more the ringing in the ears, cranial nerve palsies, changes in speech, neck pain, changes with the eyes, that inflammation of the lining of the eye, the bulging out of the eyes. So keeping that in mind. If you're seeing symptoms, then you can sort of correlate with what their symptoms are and where they might be having their clot. So what are the outcomes? When those that were admitted, 84% went home, 77% still needed to do some rehab. Status at discharge, 48% were normal, 43% had neurologic deficits, 4% died, and 5% were unknown. But long-term neurologic impairments and neurocognitive deficits occurred in 40 to 60% of survivors. Overall, they tend to fare worse than what we see in the adult population. And those neurocognitive deficits usually occur over the course of time. So in a more recent study, 20% had a normal cognitive profile. 80% had less than expected cognitive domains, testing in cognitive domains than what you would see in the normative population. And looking at all those areas, 6% performed below in all the areas. Some it was just 1 or 2, but 6% weren't all. Overall, the IQ score was lower, and 75.5% had some kind of individual education plan. And some of this information was from a study that was done in Canada, and they said normal in Canada is about 8% of the children in general would have an IEP. So the most prevalent impairments include intellectual, global executive functionings, so that memory, processing, attention, behavioral, auditory attention, sustained attention, and memory. Verbal ability was usually spared, and deficits would evolve over time. So in summary, CSVTs are rare but clinically relevant in children. And the younger they are, the more likely you're going to have them present as seizures. Usually older is more increased intracranial pressure, such as headaches or changes in consciousness. Diagnosis is only made radiographically with multiple possible modalities, and we'll talk about different modalities here in a minute. A majority of episodes are associated with underlying medical issue, either acute or chronic, so infections, dehydration, and prothrombotic states have been associated with initial and recurrence of thrombosis. Treatment is currently at the discretion of the treating provider. There's no randomized controlled trials in neonates that show that doing anticoagulation is helpful for them. There's studies that are extrapolated from adults that say with children, it is helpful to do that, and they usually have a little bit better outcomes if they are anticoagulated. So when we look at recurrence for arterial ischemic stroke, it can recur in about 10 to 30%. It really depends on what risk factors they have or what the underlying cause of their initial stroke was. Many times you'll get another stroke, maybe in that immediate post-stroke period, and usually the outcomes with that are not as good. They may not have a recurrence of stroke, but if they still have problems with some of their blood vessels, they might have TIA symptoms, so transient symptoms that come and go. Preventive treatment will vary depending on the cause. So for instance, if they have a patent forum or valley, then they might go ahead and get that closed because then that decreases their risk for embolism. But then we always talk about all the kids, no matter if it's a perinatal stroke or if they're older and they've had an arterial ischemic stroke, is looking at those preventative factors that we know that we utilize in adults, such as, don't smoke, just don't even start smoking. Make sure you have regular physical activity. Monitor your blood pressure and your lipids. Make sure that those are in normal values. Don't become overweight. Try to avoid becoming a diabetic. And avoid recreational drug use. We use things like cocaine, and sometimes marijuana can be laced with things. And we've had a couple of kids who have had strokes because of whatever they took at that time. Definitely, if you're not looking at those kind of things, you have an increased risk for recurrence. With perinatal stroke, the recurrence rate is very low. The child's not going to go through the birth process again or gestation again. And that can be where some of the problems can occur. Usually it's about 1% if no etiology is identified. And this includes with those future pregnancy risks. But if there's congenital heart disease present, then the recurrence risk is about 14%. But we usually don't recommend for either strokes follow-up brain imaging on a routine basis to try to monitor that. We treat the patient, we treat what they're doing. So now that we've gotten sort of the basis of what all these events are, what symptoms they can have with them, and then what the recurrence rates are and their outcomes, let's talk about what we do for the diagnostic workup. So we're imaging, we look at usually MRIs with a DWI, T1, T2, perfusion maybe, MRI angio with and without, CT scan might be done or CT angio. We look at laboratory testing, looking at thrombophilia, vasculitis, and then just general screening labs if those are needed. Cardiac, if there could be a possibility of a problem there, and then other targeted testing depending on the specifics. So with MRI imaging, I've already mentioned it, that is the preferred scan. CT scan does not necessarily give good results for kids, does not identify those strokes early enough like it does in adults. MRI is limited because we need sedation for younger children, not available in all areas, at least for younger children. And if it's an adolescent or even a school ager, if they have braces on, then you don't get a full view with that. And there's been the 16-year-old that I gave as the first example, we had to take her braces off so we could get good full scans for her. We need to get a diffusion weighted imaging at acute presentation because that's much more sensitive than a CT scan. And other MRI sequences such as FLAIR can also give us good information. Let's see. And I already showed you with the DWIs, a couple of those that I showed you where we see those bright spots, and that tells us that's an acute event. And then using MR angiogram, we can look directly at the vessels. If they're very small vessels, it's a little bit more difficult to take a look at those. So we may have to use other modalities. But we want to look at both the head and the neck because we have the intracranial vessels and the extracranial vessels that we want to make sure that are functioning. So going down into the carotids. The MR venogram, definitely want to do that. We want to get an MRI with and without, and then a MRV when you're looking at CSVT, because you want to look to see exactly with those reconstructed images, what's happening within those venous sinuses. And then we can do vessel wall imaging used to help to differentiate when we're looking at vasculopathies or arteriopathies. And it really shows inflammation in the vessel wall. So it will have an enhancement around different vessel walls. So it's very helpful when you're looking at those kind of diagnoses. Other imaging, CT scan, which is usually the hallmark for anyone a child comes in, like if they've fallen, which is really good for identification of intracranial hemorrhage, but not so much when identification of stroke. It fails to identify it in more than 40% of children because it's not as sensitive for assessing acute ischemia, or in adults, it can do that. There's also the risk for more exposure to radiation with CT scans and also with CT angios. The CT angio gives a really good, nice look at the vessels, but definitely gives a pretty hefty load for radiation with that. And you can also do a CT venogram. Equally as sensitive as the MR venogram for that CSVT diagnosis. But we try to avoid using CT because of that radiation. We do utilize them if we need to get a better look at vessels more often. And this gives just a really good example of, here's the initial CT scan, which was read as normal. This was the MRI T2 scan. And you can see in the left parietal lobe, you've got some enhancement in this area right through here, wedge-shaped area at that parietal occipital junction, and then even a smaller area more superiorly, which you can better see on the flare through here. And then also you're seeing that enhancement there, but not seen on that CT scan. So that's why there's a reason that we do the MRI scans for children. We may also need to look at conventional angiogram if we really need to get a good look at the vessels. And, you know, it's minimally invasive using a catheter, but they have to be sedated. You're using lots of contrast. It's done in real time. It's very useful when you're trying to diagnose, you know, specific aneurysms or malformations, really assessing those vessels. So it's not used on a routine basis. Many times if we're doing serial scans or we're trying to monitor something, we might do an angio once or maybe a CTA once, but then continue to monitor it with the MRI. So this just gives an example of a conventional angiogram. You've got your internal carotid artery coming up to the MCA. Here's the M1 segment, M2, and then going on up for the superior and inferior divisions, same kind of thing, internal carotid. There's the right MCA, and then you've got your branches. This also shows the anterior cerebral artery and the ophthalmic artery. And it's important to know that because when we talk about some of our special situations, moyamoya disease, this is normal vasculature on the right. And then on the left, you see all these moyamoya vessels where it just sort of looks like a puff of smoke. You're not seeing the branching. You're seeing vessels that are sort of very small and just blooming out. When we look at cardiac evaluation, we're checking for any kind of cardiac concerns, doing EKG, and then doing an echocardiogram. Most often it's a transthoracic, and we also do that with a bubble study because we want to check to make sure there's not any right to left shunting within the heart. So that can identify a PFO for that. Just looking for any kind of cardiac source that might be embolic. If you need to get a really good look of the entire heart, you might need to do a transesophageal echo. And if you do that, if you're still thinking cardiac, but your transthoracic was normal, it gives you a much better image of that. And you definitely can see the posterior aspects of the heart. And then other targeted testing is done when there's a concern regarding any kind of epileptic seizures. We might look at EEG. And then transcranial Doppler is used for those children with sickle cell disease to monitor the blood flow in some of their major vessels in their head. And then to monitor that, and when they're starting to see slowing of that, then we start interventions. So our keys to stroke management is neuroprotection. You know we have that delay in diagnosis, getting to imaging. You know, we have to need sedation for some of the imaging. They might need to be transferred to another center, or there's not availability of them to be seen at that center. So we try to prevent secondary injury by maintaining a normal blood pressure, making sure that they've got good oxygen levels, temperature is stable, looking at glucose regulation. And then some newer avenues that have been utilized in the adult population are things like recanalization therapy. So if we see that they have a clot, then what kind of other things can we do to try to get rid of that clot, like they've been doing with the adult population? So we have to limit, though, who we use this on, because there's not been a lot of data that's been extrapolated. So they have to limit children from meeting just certain criteria. They have to have persistent disabling neurologic deficits. There is a PEDS version of the NIH stroke scale that we use. And if that's greater than equal to 6 at the time of intervention, they meet the criteria. And then radiographic confirmation of a cerebral artery occlusion is identified. So with these children, we have used TPA for them, where in adults, you try to do 4.5, get it in within 4.5 hours. And the problem is that we don't really know what the optimal TPA dose is, because there's developmental hemostatic changes that occur in children that sometimes the dosage needs to be adjusted. Plus, many times we're way out of that time frame to get them. We're out of that 4.5 hour symptom onset time frame. Intra-arterial TPA has been used, usually within 6 hours of symptom onset, and many times we can't get to them that quickly. Then there's mechanical thrombectomy. Again, guidelines are extrapolated from adult trials. It can be done within 24 hours of symptom onset, only for those larger vessels with occlusive strokes. And we know that within the adult population that they do tend to have greater improvement with thrombectomy versus using IV TPA. So it has been used in children up to 2%. They need to use this in a dedicated pediatric stroke center. There's not controversy, but debate about do you use a stent retriever versus aspiration. It's really dependent on the size of the patient. Aspiration, I think, is used a little bit more often because you don't have to worry as much about the size of the vessels. But should not be used if you think arteriopathies are suggested, because you can get more damage to the blood vessel. And then the other parts with treatment with them is the need for rehabilitation. It really depends on the deficits they have. So therapy is key. And that's what I tell parents. It's like, there's not really medicine that they need to take, but we need to do therapy, because that's what's going to help with that neuroplasticity of the brain, helping to rewire some of those areas so we get the most optimal function. So early onset of therapy is very beneficial, whether they need OT, PT. When they're very young, OT or PT pretty much work the same. Speech therapy, not usually started until they're more towards a year age, unless they're having problems with feeding. Recreational therapy for those that are older, and then constraint therapy, which we're going to talk a little bit more about. And then the other thing, it's not really therapy, but the other thing we need to really be aware of is, they can have deficits, neurocognitive deficits that occur later. If you think about normal development, you don't worry so much about can they count to 10 until they're getting more towards, 3 or 4, or when they're ready to go to school. So that's where neuropsychology comes in and plays with that. We want to make sure that they've got the appropriate accommodations for school. And if they need to have an IEP or 504 plan, to have that available. So constraint-induced movement therapy is constraining the unimpaired or the less impaired upper extremity. And then it's in high and concentrated dosage of therapy, so a certain amount of hours per day for at least 10 days. The principles of it are that there's behavioral shaping and mass practice to elicit and improve neuromotor control of the hemiparetic upper extremity. So been used with stroke, been used with patients with CP. Sometimes there may be more modified, because then that does not include all of the components of the typical constraint. And that's been tested more often with children. It's one of the few therapies that produces clinically meaningful and sustained benefit for children with hemiparesis. It's even been used on some older children too, with some good results. The limitations with constraint are that there's so much variability within the specific treatment protocols that have been used, the children that are used, the criteria for choosing the children, and then the type of constraint applied. So is it casting? Is it a rigid constraint? Is it soft? How is it constructed? And then the amount of time that's being used. So that dosage and amount of constraint therapy measured in terms of the treatment hours per session and the total number of treatment sessions. So there's multiple trials going on right now to try to figure out what's the right dose for constraint and induced movement therapy. And one of the trials we're involved with at Children's right now is the iAcquire study, where we're looking at children 8 to 36 months of age that have had a stroke early in life, now showing some motor weakness or poor control of movements. They get therapy 5 days a week for 4 weeks, and they're divided into 3 groups. The first 2 groups have varying amounts of time for constraint, and the third group continues with their normal therapy, and then they'll have the opportunity to participate in groups 1 or 2 once they've gone through the regular therapy for 6 months. This trial is across 12 locations in the United States, and therapy is provided in their home or a home-like setting. So some of our patients will come and spend their time at our Ronald McDonald House for those 4 weeks. They'll spend the week there, go home for the weekend, come back, and then start the process all over again. So it's in a home or a home-like setting. It's free of charge, and they do use a cast. So it's a rigid constraint, but it's removed at least once a week so that we can make sure that there's no skin breakdown. So the goal of this is to figure out what's the right amount of dosing for this, because it's so variable, and to try to get some really good data with this. And so the study is still ongoing. So talk about it in the future. But this just to give some examples of what's been used. This is an oven mitt that is then has a sort of a sling around it that is used. So it's used on the good arm so that the more functioning can be for the affected arm. This is more of a rigid restraint. So this is more like a splint, and then it's got a wrap around it. So again, we're trying to teach the brain to rewire itself following the brain injury. Again, utilized a lot with CP, but very effective for stroke. So I just wanted to mention a couple of special circumstances with stroke cases. The first one being moya-moya syndrome. And this is characterized by a progressive stenosis of this terminal portion of the intracranial internal carotid arteries, or the proximal portion of the anterior cerebral artery, or the middle cerebral artery. And you develop this network of abnormal collateral vessels that look like a puff of smoke for the tangled vessel to form to compensate for the blockage. There's different criteria for it. And it can be caused by or associated with lots of different things. So again, this is an example. You've got your carotid coming up through here, and then you just have this sort of tangled web of vessels. When the angiogram's done and they do the blush with, it just looks like somebody's blushing with that. So it can be idiopathic. I have a few children that I take care of that have it because of neurofibromatosis type 1, a few from Down syndrome, sickle cell, other hemoglobinopathies. So can be associated with other things. Most people associate it with sickle cell. And then treatment is they'll do a pleosanangiosis, either indirect or direct, meaning they'll take a blood vessel and then they lay it right along the scalp, and then with the hope that blood vessels will grow into, not along the scalp, but along the brain, that will grow into the brain and then provide that collateral circulation, and usually fairly effective. But the risk is that an event where they will have a stroke. And sometimes that's when it's identified, is that they've had a stroke, and then we find that they have moya-moya. So, but with those children with sickle cell disease, we know that they're more at risk for silent infarctions, strokes, seizures with strokes, sinus venous thrombosis, cerebral hemorrhages, and hyperviscosity syndromes. So we try with them to prevent them from having a stroke. And because the concern is for that development of moya-moya. And silent infarcts are treated with exchange transfusions. So in normal care for sickle cell disease kids, they do have a transcranial Doppler that's done. Those measurements are taken on their routine visits. And this has reduced their risk by 92% by doing that. If they are doing normal, they may just be on hydroxyurea. If they're found that this transcranial Doppler is slowing, then they will go to exchange transfusions. If they've had, and then, investigation for silent infarctions. If they have a silent infarction, they're on exchange transfusions. If their TCD improves, which it usually does not, but if it does, then they may be switched back to hydroxyurea. And then we just continue to monitor them with serial scans once a year or more often, depending on them, to monitor for any development of arteriopathies. And I just wanted to mention too, thrombosis and COVID-19 infection. We know that with COVID-19 infection, there was an increase for thrombosis risk, not seen as much with the pediatric population. We think it's related to that cytokine storm, and because that's a major pathophysiologic bridge between inflammation and thrombosis. Children have developed MIS-C, which is multi-system infection that can arise even weeks after having that initial COVID infection. We know that those thrombotic or thromboembolic events are rare in children, especially in those with comorbidities predisposing them to a thrombotic event. But MIS-C can give them persistent fever, inflammation. They can have symptoms of Kawasaki disease, which can affect the coronary arteries, shock, multiple organ failure, and even death in those that were severely ill. So there was some coagulopathies that were associated with multisystem inflammatory syndrome in children. 71% that developed it despite already being on thromboprophylaxis. If they had a thrombotic event, mortality was much higher, 28%. Risk factors include older age, if they already had cancer, if they had a central venous catheter, if they developed MIS-C, but still very low. Most common was actually a deep vein thrombosis, where stroke and CSVT rarely occurred. So it did increase their risk slightly, but not as much as what we saw in the adult population. So what are some of the future directions for pediatric stroke? In the perinatal world, they're truly trying to search for the disease biology. What are some other things that we can do to help prevent? We know what some of the risk factors are, so better pregnancy care, better neonatal care, but what are some other things that we can do to maybe help prevent this? For childhood stroke, better definition and treatment for cerebral arteriopathy. That seems to be our buzzword right now, is that we're really looking at what's causing the inflammation of those vessels and what can we do best. We have treatment dilemmas. In the hematologic world, they look at following either the Canadian best practice guidelines or the CHEST guidelines. So trying to have a unified guideline to decide when we need anticoagulation for these patients. For neonatal CSVT, we look at earlier diagnosis and treatment. And then rehab, really harnessing that plasticity of the developing brain, figuring out with constraint therapy, what is a good dose for that? And then taking all this research that we're doing and translating it into practice, just like we do with all areas. So in summary, I really just want to bring forth that, we know that children have stroke. So remembering with teens and children, we need to think about those symptoms that we would normally see with a stroke, remembering that facial droop, arm drifting, speech slurring, and knowing that time is critical, so we need to act fast, but also adding an R to that. So we're looking at faster, because remembering that kids have strokes too. And sometimes their symptoms may not be exactly what we talk about with fast. So for, a neonate, think of encephalopathies, sleepiness, trouble staying awake, dizziness or coordination problems, severe headache, out of their norm, nausea and vomiting without fever or other illness, waking from sleep, altered consciousness, or new development of seizures. These can all be things that can be the first symptoms of stroke. And I just wanted to share this with everyone, letting them know that strokes can happen at any age. This is American Heart Association, American Stroke Association, that really talks about not only the perinatal stroke, but the childhood stroke, what the risk factors are, warning signs, remembering time is brain at any age. Here are some resources. We have our Stroke and Vascular Anomaly Clinic at Nationwide Children's Hospital. The Children's Hemiplegia and Stroke Association, or CHASA, is an excellent organization, lots of really good resources. Pediatric Stroke Warriors, Sickle Cell Disease, and the International Alliance for Pediatric Stroke. Have lots of different references, and my contact information was on the first slide. So if there's any additional questions or concerns, or you're needing stroke resources in your own areas, please feel free to reach out to me. Thank you very much.